cardiomyocytes exactly based on the location of their nuclei. In cardiomyocytes, the nuclei are centrally located, while in skeletal muscle cells, there are multiple nuclei which are peripherally located next to the cellular membrane. I may try to find, here there is another area where we have a longitudinal section through the cells, so they are really long, and again we can find the nuclei of the cardiomyocytes in the central portion of the cytoplasm. Another thing that is obvious is the granular yellowish pigment surrounding the nuclei. This is lipofuscin. You know that this pigment is formed due to aging. Here again, it is seen in almost any cell. Due to aging, because of the lipid oxidation of the cellular membrane, phospholipids. Just a second, I'm sorry. Sorry, I'm back again. The other thing that is obvious on the slide is that some of the cardiomyocytes look different, like in this area that is more eosinophilic. And when we zoom in, we can find that these cells do not contain nuclei, and their cytoplasm is hyper-eosinophilic. You know that this means that there is necrosis of the cardiomyocytes. So some of the cells show features of necrosis compared to others that are still normal. Maybe a little bit hypertrophic. I think there are some other areas. So at low magnification, at the more eosinophilic zones, you can find some patchy necrotic areas. Here again. Here we can find some too. At the left side, even at low magnification, the zone is more eosinophilic. And when we zoom in, we can't find the nuclei of the cells. And their cytoplasm is hyper-eosinophilic. After we recognize the organ, this is the heart, we can find that in the cavity there is something wrong, something that shouldn't be here, and it is exactly a thrombus. Even at low magnification, we can find some alternating zones. Some of them are paler compared to the adjacent ones that are reddish in color. This is because of the components of these areas. The reddish ones are composed mainly of erythrocytes, while the paler zones contain fibrin strands. This meshwork, pinkish meshwork, is the fibrin strands intermixed with white blood cells and thrombocytes. You know that grossly these lines, alternating lines, are known as lines of Zahm. So finally we can make the diagnosis, a thrombus in the heart. The name of the slide, it's written only mixed thrombus, because in the past it was written that it's in an atrium. Honestly, here, just based on the slide, we can't say exactly which part of the heart this is. but at least the cardiomyocytes are well visible. You know that after you describe the slide, you can be asked anything like the Virchow's triad or what is the mechanism of developing of the thrombi, what could be the cause. We already discussed the causes during the classes, like the myocardial infarction, for example, could be a cause. There is some evidence of myocardial infarction here. And due to the damage of the endothelium together with the turbulent blood flow that is formed because of the abnormal contraction of the skeleton of the myocardial muscle, this leads to formation of a thrombus next to the myocardial infarction. Other causes could be valve disturbances like stenosis or insufficiency. Usually they are also associated with formation of thrombi, usually in the atriums. Questions? Okay, we continue with slide number 4, which diagnosis is cellular embolism. But before we discuss the tumor emboli, we need to recognize the organ, of course. The thing that is quite obvious, I think, is the lung parenchyma. Even at low magnification, we can find many empty spaces. When we zoom in at these empty spaces, we can find that these are the alveoli. We can also try to find a bronchus or a bronchiolus. There is something here, the left side. It looks like a lumen lined by epithelium. When we zoom in, we see that this type of epithelium is pseudostratified columnar ciliated epithelium. There is no cartilage or glands in the wall, which means that this is a bronchiolus, but not a bronchus. And then, at low magnification, we can detect some dark areas. You know that this is anthracotic pigment in the interstitium. These are the coniophages. So all of these structures help us say that the specimen is from the lung. But then, even at low magnification, it's quite obvious that there are some darker zones. These darker zones are exactly the vessels which are filled with tumor cells. You know that the tumor cells show features of cellular atypia. Actually, the malignant tumor cells show features of cellular atypia, one of which is and when we can find exactly these features of cellular atypia in cells which are found in vessels. So here we have the increased nucleus to cytoplasmic ratio, hyperchromatic nuclei, presence of nucleoli, these prominent dots in some of the nuclei. Here as well, nucleolus. And tumor cells form specific structures. These specifics. So we have some of them are even filled with mucin. This bluish material is mucin. Mucin or mucus. These are synonyms, doesn't matter which word you use. Some other things forming structures in this vessel, just cells peripherally, the tumor cells, there is a free space from the lumen of the vessel. Of course, if there are no erythrocytes in the lumen, it's not that easy to say if this is a blood vessel or a lymphatic vessel. But especially here, in this case, obviously this is a blood vessel because around the tumor cells, there are erythrocytes, which means that this is a blood vessel. When one tumor forms glands, you know that it means that this is adenocarcinoma. So here we can discuss that these tumor emboli come from a primary tumor, which is adenocarcinoma. It could be from the colon, from the stomach, it could be even from the lungs. Here again, you can find them. But don't forget that presence of tumor emboli does not mean that there is metastasis, because while the tumor cells are still within the blood vessels or lymphatic vessels, this is only tumor embolus. It will be metastasis if these tumor cells leave the blood vessels or lymphatic vessels in a new place, like here. These tumor cells may leave the vessels in the lung parenchyma, starting to proliferate and forming a secondary mass. I call it a secondary mass because obviously this is not the primary site of the tumor. There is another primary site which gives these tumor emboli, and then if these cells leave the vessels in the lung parenchyma forming a secondary mass, then it will be a metastasis. But at this moment, this is still only tumor emboli, but no, not metastasis. Questions? Okay, we'll continue with slide number 5, which is the spleen infarction. The infarction is obviously involved in the right side of the slide because here is the pellar area due to the absent nuclei of the necrotic cells. And initially we'll zoom in at the left side of the slide where we can find the normal spleen parenchyma. Of course, we should try to find some normal structures from the white pulp. And yes, at low or medium magnification, we can still detect some, I would say, remnants of follicles here as well. Because this is not their normal size, there is atrophy or autolytic changes because the specimen is taken from a dead person. Here we have some remnants of the lymphocytes, and don't forget about the centrally placed arteriole that is characteristic exactly for the lymph follicles in the spleen. Such a centrally placed arteriole is absent in the lymph nodes. So this is the thing that shows us, or at least one of those that show us this is a specimen from the spleen, presence of lymph follicles with centrally placed arterioles. Here again, there is a follicular structure with centrally placed arteriole. Another characteristic morphological finding in the spleen are the spleen trabeculae. These pinkish structures, elongated structures, these are the trabeculae. When we zoom in, we can see that they are composed mainly of smooth muscle cells intermixed with fibroblasts. If there is blood loss from the body, then these trabeculae may contract because of the presence of smooth muscle cells and pump the blood which is within the red pulp into the circulation to try to compensate the lost blood. Yeah, I mentioned the red pulp, but it is composed of sinusoids, you know, it is elsewhere in between the lymphoid follicles. And then we concentrate on the appearance of the infarcted area. It is paler at low magnification because of the absent nuclei of most of the cells, and their cytoplasm is hyper-eosinophilic. But note that there are still schedules of normal structures like lymph follicles with centrally placed arterioles. So these schedules of structures still show us which is the organ because of the type of necrosis. This is coagulative necrosis, which is exactly characterized with the fact that the structures are, or schedules of structures are still preserved, although the cells are necrotic. And at the lower side of this necrotic area, in the middle, there is an artery. We know that this is an artery because of the thick muscular wall and also because of the presence of an elastic membrane. This curvy line is the internal elastic membrane of the artery. And within the lumen of this artery, there is something that looks like a thrombus. Peripherally, we have an area that resembles a meshwork of fibrin strands, and next to it there is a zone with erythrocytes. Of course, to confirm that this is a thrombus, we should perform a special staining for fibrin. In this case, the special staining that is in the lumen of the artery, it will mean that this is a thrombus or an embolus, thromboembolus, which comes from a thrombus formed in another site, and then this will be the cause for infarction. You know that infarctions usually are caused, or in most of the cases are caused, due to complete obstruction of an arterial blood vessel leading to hypoxia and complete ischemia to the supplying area. Questions? We continue with slide number 6, myocardial infarction. On this slide, we can find the three layers of the heart: myocardium, the upper 2/3, even more of the slide. Epicardium is the layer composed of fat tissue, and pericardium is the uppermost layer. In this case, it is the lower side of the slide. We'll start with the myocardium. Trying to find necrotic and normal zones. Even at low or medium magnification, we can find some darker zones. You know that the darker area in the infarction comes from the fact that the cytoplasm is hypereosinophilic, while the normal zones look paler. And yes, when we zoom in at the border of these two areas, on the right side, we can find some cardiomyocytes with still preserved nuclei, again, presence of lipofuscin, this granular yellowish pigment. I think that I forgot to mention the difference with the hemosiderin, because with hematoxylin tausin staining, you know that the hemosiderin would look the same way. So if we want to distinguish them, again, we should perform a special staining, which is Pearls staining for iron, and then only the hemosiderin will be covered in blue because it is an iron-containing pigment, while the lipofuscin does not contain iron, so it won't be covered with Pearls staining. Then we change the picture to the necrotic area. And yes, here we can find, again, only schedules of cardiomyocytes. The type of necrosis is coagulative too, like on the previous slide. That's why we can find the schedules of cells, but at the same time, they do not contain nuclei. Only the pigment is still visible. And the cytoplasm is hypereosinophilic. The other thing that is quite well visible is the presence of inflammation in the interstitium surrounding the necrotic cardiomyocytes. You know that necrosis is always associated with inflammation, in contrast to apoptosis, which does not trigger inflammation. But here in the interstitium, obviously, we can find predominantly neutrophils. If you remember, when we discussed infarctions, we mentioned that this dense neutrophilic infiltration usually is formed during the second day from the onset of the infarction, second and third day. So here, if you are asked how old is this infarction, you can mention that due to this well-preserved neutrophilic infiltration, it looks like the second or third day from the onset of the infarction. There is also erythrodiapedesis, so the presence of leukocytes in the interstitium is known also as leukodiapedesis, and the other thing that is visible is erythrodiapedesis. It occurs due to the fact that in one necrotic area, not only the parenchymal cells undergo necrosis, but there are degenerative changes of the blood vessels that are in this area, and the blood cells can leave the blood vessels and move in the interstitium. So this is the leuko and erythrodiapedesis. Again, as a cause of the infarction, if you're asked, it must be occlusion of an arterial blood vessel. In this case, for the myocardium, it must be a coronary artery. Most commonly, it is obstructed by an in situ formed thrombus over a complicated atherosclerotic plaque. but it could be also due to an embolus. There is also something over the pericardial surface. When we zoom in at this area, so here this is the pericardium lined by one layer of mesothelial cells, but we can find that there is also an area with a deposition of something. And this thing looks like fibrin, meshwork of fibrin strands intermixed with inflammatory cells. Again, the neutrophils are quite well visible. So based on these morphological findings, we can say that there is fibrinous inflammation on the pericardium or fibrinous pericarditis. Don't forget that next to the area of myocardial infarction, in the lumen, there could be formation of a thrombus. We already mentioned it. Here on this slide, thrombus is not visible. But on the outer side of the slide, on the other side of the heart, again, next to the myocardial infarction on the pericardium, sometimes fibrinous pericarditis is formed. And this is the mechanism of developing of localized fibrinous pericarditis, which is known as pericarditis epistenocardica. Pericarditis epistenocardica is the term sorry, used for the fibrinous localized fibrinous inflammation formed next to the or over an area of myocardial infarction. Questions? We continue with the next slide, number 7, pulmonary infarction. Yeah, I didn't mention it, but on the previous 2 slides in the spleen and the myocardium, we saw the type anemic or white infarctions, while here in the lungs, the type of infarction is hemorrhagic. That's why the infarcted area is reddish in color. So initially we'll zoom in on the left side of the slide where we can still find the normal lung parenchyma composed of alveolar spaces again. These alveolar spaces are filled with many siderophages or hemosiderin-laden macrophages. These are synonyms. But note that the alveolar septae are still lined by the alive alveolocytes. So we can find the nuclei of the alveolocytes that align the alveolar spaces. This won't be visible in the area of the infarction. About the siderophages that fill the alveolar spaces, when we discussed the hemosiderosis of the lungs, we mentioned that usually the cause is chronic left-sided heart failure. But in this case, with a hemorrhagic infarction, we can't be exactly sure if these siderophages formed surrounding the infarction are not due to some erythrocytes that move to the alveolar spaces. So, of course, in this case, we need the whole appearance of both lungs. And if these siderophages are seen elsewhere in all of the lobes of the lungs, then it will be evidence for chronic left-sided heart failure. But if localized surrounding the hemorrhagic infarction, and now when we zoom in at the area of the infarction, two cells are still visible. Both of the processes, the alveoli will be filled with erythrocytes, like it's here. But exactly the difference is in the necrosis of the alveolocytes. If this is pulmonary infarction, like on this slide, then the alveolocytes will lose their okay. Here you see normally look the left. But these alveoli that are lined by alveolocytes will be filled with erythrocytes, and then it will be only hemorrhage. So here the presence of necrosis of the cells is an evidence for infarction. There are, of course, some white blood cells, but again, this is due to the inflammation associated with the necrosis. And the siderophages, again, are formed because of the extravasated erythrocytes. You know that the hemosiderin is formed after the alveolar macrophages phagocytose the erythrocytes, and then the hemoglobin is transformed into hemosiderin. Actually, for such a large pulmonary infarction to develop, usually lung congestion is needed. You know that lung congestion is the manifestation of chronic left-sided heart failure. And it's needed because the chronic left-sided heart failure is also associated with some ischemia. And then if there is subsequent embolization or pulmonary embolism, then with these two events, the lung congestion together with the pulmonary embolism, then it leads to formation of a hemorrhagic infarction. And the type of the infarction is hemorrhagic because of the dual blood supply to the lungs. Questions? won't zoom in at this area, but in the other more eosinophilic zones where we can find some normal cells from the brain. And when we zoom in, we can see some large cells with larger nuclei. These are nuclei of neurons. And around them, we can detect some smaller nuclei that look like dots. These are the nuclei of glial cells. You don't need to recognize the different types of glial cells just based on the hematoxylin staining, but you can be asked theoretically about the different types of glial cells and what is their function. There are 4 different types of glial cells. They are astrocytes, oligodendrocytes, and microglial cells. The function of the microglial cells is macrophageal. They are the macrophages in the brain. Don't forget that the empty spaces that are formed surrounding the cells and surrounding the blood vessels, they are called perivascular and pericellular clear spaces. They are an evidence for brain edema. We can detect this pathologic finding in any specimen, histological specimen that we have from the brain. And then we move to the necrotic area. I already mentioned that it looks like a cavity, and yes, when we zoom in, we can see that this empty space actually is a cavity that is filled with lipophages. Lipophages are macrophages filled with lipids, and they are the ones with bubbly cytoplasm, foamy cytoplasm. But at the same time, we can find also some macrophages that contain pigment. And this pigment, in the case of a brain infarction, is hemosiderin. Of course, we can use the special staining to confirm the hemosiderin. Here the hemosiderin comes from the fact that there was a previous erythrocytes deposition in this area, which means that this was a hemorrhagic infarction. You know that in the brain, both types of infarctions are possible, anemic and hemorrhagic. So finally, based on the presence of the type of macrophages within the cavity that is finally left from the infarction, we can say what was the type of the previous infarction. So here, in the case of so many siderophages within the cavity, means that the infarction was hemorrhagic. Because only in the hemorrhagic infarction there is leakage of erythrocytes within the necrotic area. Also, don't forget that this cavity finally formed after the brain infarction is known as a pseudocyst. And it is a pseudocyst because of the absent epithelial lining. This is the difference with the true cysts. Next year when you So this is the end stage of a brain infarction. It takes a few weeks to develop. Here in this slide, we do not have a fresh infarction like it was in the myocardial infarction and in the pulmonary infarction. Here, this is a note infarction. It takes at least 4 weeks. Of course, it depends on the size of the infarcted area, but at least 4 or 5 weeks are needed for this pseudocyst to develop, which means that the whole necrotic material is completely removed by the macrophages. And also there are many lipophages because of the fact that the brain parenchyma is rich in lipids. And when these macrophages phagocytose the necrotic material, which is rich in lipids, they become lipophages or lipid-laden macrophages. Can you start from the beginning?
Is the only thing that makes it recognize that this is an old hemorrhagic infection?
There is a question here how we can recognize if this is an old infarction or a fresh one. And yes, only the presence of macrophages and the absent necrotic tissue. If it was a fresh infarction, there will be an area of the brain parenchyma with necrotic cells. But here the necrotic debris, the necrotic area is completely removed and only macrophages are left, which means that it's an old one. Otherwise, in the early stages, we can always find the necrotic parenchyma, doesn't matter which organ it is, but we can see the necrosis of the cells. Any other questions? Then you continue with the next slide, number 9, myocardial cicatrix. The cicatrix is the paler zone, and the more darker area, this is the normal myocardial parenchyma where we can recognize the cardiomyocytes and the organ. So of course, initially we'll zoom in at the darker zones, and here again we can find the same findings. Characteristic for the myocardium, the cardiomyocytes with centrally placed nuclei, the lipofuscin that is perinuclearly located. Note that there is no fresh necrosis on the slide. These cardiomyocytes are normal. Even in some of them, especially next to the fibrotic area, some of them are highly hypertrophic. Here again. But all of them are still alive. They do not show features of necrosis. Really doesn't matter where you zoom in, you can find the same things. Cardiomyocytes with hypertrophic changes. But at the same time, we can find many areas in between these cardiomyocytes with lost parenchyma, which is completely replaced by fibrous tissue or connective tissue. These are synonyms, doesn't matter which words you use. And this is an evidence of an old infarction. The replaced myocardial tissue means that it was necrotic, and then with time you know that initially there is necrosis, then inflammation, then the macrophages come to phagocytose the necrotic material. At the end of the first week there is formation of granulation tissue that always starts from the border between the normal parenchyma and the necrotic zone. So there is granulation tissue. It's not visible here. All of the things that I mentioned are just theoretical findings because you can be asked about the different changes of the necrotic area in the time duration of the infarction. So initially, at the end of the first week, there is a formation of granulation tissue. You know that the granulation tissue also contains fibroblasts that produce collagen, and with time, these fibroblasts proliferate and produce more and more collagen, eventually leading to formation of a matured connective or fibrous tissue. Like on our slide, this is what we can see here. Areas which are composed entirely of matured connective tissue. This is the end stage of the end stage of the infarction, known as myocardial cicatrix. It takes at least 6 weeks to develop. So if you are asked how old is this infarction here, you should mention that it's at least 6 weeks, because once the connective tissue is formed, here I can't tell you exactly if this is 2 months, 6 months, or 2 years after the infarction. It will look the same way once the matured connective tissue is formed. So you mentioned that it's at least 6 weeks, because before 6 weeks, we'll see still some granulation tissue. During the first days or the first 1-2 weeks, we will see even the necrotic cardiomyocytes with inflammation and so on. Myocardial cicatrix. This is also the name of the slide in your list of specimens. Another thing that is visible on the slide is the foci of matured fat tissue dispersed here and there in the connective tissue, the whitish spaces. These are the zones with adipocytes, with fat tissue. But don't discuss this finding unless you are asked. But I think you will be asked, because in third year you studied these pathological changes. So here the presence of adipocytes at an abnormal place, because normally within the myocardium there shouldn't be any fat tissue, which means that here the presence of this mature fat tissue means that this is something abnormal for the myocardium, and this is known as lipomatosis. Note that this process is different from fatty degeneration. Fatty degeneration means that there is deposition of lipids, but within the parenchymal cells of the organ. In this case, the parenchymal cells are the cardiomyocytes. So if you call the process fatty degeneration of the myocardium, it means that the lipid deposits are within the cardiomyocytes, which is not true here. So your answer will be wrong. Here we have infiltration by adipocytes, which are mature mesenchymal cells, at an abnormal place. And this process is known as lipomatosis. Questions? Slide number 10 is the next one. Liver steatosis. exactly what we just discussed. So liver steatosis is an example of fatty degeneration, because here the lipids are exactly within the parenchymal cells of the organ. In this case, of course, the parenchymal cells in the liver are the hepatocytes. But before we see the fatty deposits, we need to recognize the organ. Honestly, it's not that easy for this slide, because we have really diffuse fatty degeneration. All of these lipid droplets, these white droplets, these are exactly the lipids. So at the beginning, if you get the slide, please use the medium magnification, at least at low magnification. I am sure you recognize the slide and you'll be able to make a diagnosis. But then to find some normal structures to confirm that this is a specimen from the liver, use the medium magnification and try to see some round to oval structures in which you can find several lumina, because these are the portal triads. Here again, we can find one. And then when you zoom in the portal triads, you can see that there are blood vessels. You know that there is one venule, which is a branch of the portal vein, an artery, which is a branch of the hepatic artery, and also a bile duct. Don't forget that the bile duct is histologically distinguished from the vessels based on the epithelial lining. The bile ducts are lined by cuboidal cells with round nuclei. This is in contrast to the blood vessels, which are lined by endothelial cells. The endothelial cells are flattened cells with elongated nuclei. This dark line, this is the elongated nucleus of the endothelial cell. This is another portal triad. In this case, the bile duct is the upper side. This lumen belongs to the bile duct because of the epithelial lining again. We can find the cuboidal cells with round nuclei. The other two are the blood vessels. Usually the larger one with thin wall is the venule or the vein, and the arteriole is the smaller one with thicker wall. And the last example here, the bile duct is at the lower left side. The other two are blood vessels. Don't try to find central veins in this case, so the architecture is still preserved, but the central veins are it's really difficult to find the central veins exactly because of these diffuse fatty deposits. And you know that the fatty deposits are or look like clear vacuoles because of the fact that the lipids are not here. This is due to the routine processing of tissues, which leads to washing out of the lipids during the time when the specimen goes through different concentrations of alcohols. This leads to washing out of the lipids. So finally, when we perform the hematoxylin staining, the lipids are not within the vacuoles. That's why they occur as empty spaces. If we want to confirm that these are lipids, but not cellular edema, for example, then we should perform, first of all, frozen sections, and then to stain the tissue with oil red, Sudan-free, Sudan-Schwarz. These are special stainings for lipids. With Sudan-free and oil red, the lipids will be covered in dark orange to red. With Sudan-Schwarz, obviously, they will be in black. The other thing is that we distinguish two different types of steatosis. It is microvesicular and macrovesicular. Microvesicular steatosis is when within one hepatocyte we can find several smaller lipid vacuoles, like here. Here again we have one hepatocyte with 1, 2, 3 lipid vacuoles in the cytoplasm. This is microvesicular. The other variant is macrovesicular, and in this case we see only one large lipid vacuole pressing the nucleus to the peripheral portion of the cell. Not in all of the cases the nuclei are well visible. That's why please try, if you get the slide during the exam, please try to find a hepatocyte where you can well see the lipid vacuole and the pressed nucleus peripherally. Of course, the cell really increases its size if there is such a large lipid vacuole, and in some cases the cut section could be not through the nucleus. That's why it's not visible. And after you describe the slide, you can be asked about different causes for steatosis. You know, it could be diabetes mellitus, alcohol consumption, obesitas as well. Just a second. I'm back, sorry again. I mentioned the causes that you can be asked. And also, of course, the outcome of the process is another commonly asked question, or if this is reversible or irreversible pathological process. It is completely reversible. If we remove the pathologic cause, then these lipids could be removed from the hepatocytes. Questions? The next slide is number 11, petechial hemorrhages in the brain. I think that the hemorrhages are quite obvious where they are, but at the beginning we won't concentrate on them, but on the appearance of the brain parenchyma. The peripheral pallor area is the brain cortex. So here is the zone where we can find the bodies of neurons. While in the central portion that is more eosinophilic, this is the area where we can find the only processes of neurons with glial cells. So the thing that we care about here to recognize the organ is the cortex. Where we can well find the pyramid neurons. The shape is quite well visible here. These large cells with pyramid shape are the pyramid neurons. Around them there are smaller cells with round nuclei. Again, they are the glial cells. And of course, the evidence of a brain edema is visible here as well as pericellular and perivascular clear spaces. And then we concentrate on the appearance of the hemorrhages. They are dot-like hemorrhages, and in some of them we can find the or the pallor area. In this pallor area we can find actually the small blood vessel from the microcirculation, usually capillary, which with still preserved wall, and only the erythrocytes leave the blood vessel into the perivascular space, forming the petechial hemorrhage. The presence of such a small blood vessel, capillary, in the center of the hemorrhage helps us see the mechanism of hemorrhage. This is the perdiapadesin mechanism, which may occur only around the blood vessels in the microcirculation because of the thin wall, where it's possible the erythrocytes to leave the blood vessel lumen into the surrounding space. Here again, we can find the capillary in the center and then the hemorrhage. The other two mechanisms of hemorrhages are perdiabrosin and perrexin. Perdiabrosin mechanism is when the blood vessel wall is damaged due to an external pathologic process. And the classic example is at the base of an ulcer, of a stomach ulcer, for example. Well, perrexin means that there is a rupture of the blood vessel wall. This is in case you are asked. But here you mentioned the perdiapadesin mechanism. As causes that may lead to such an appearance of the brain with petechial hemorrhages, it could be hypertension, benign hypertension, abrupt increase in the blood pressure. And the other cause could be some infectious diseases, for example, that are associated with damage of the endothelial cells, making the blood vessels more permeable. Do you want? The last cause was about the infectious disease that is associated with endothelial cell damage. Making the blood vessels more permeable.
I didn't understand why did I let cells move around, like making the empty space in the middle?
In the middle, it's not exactly empty space. We can still find the lumen of the capillary. And here there are some blood vessels as well. They are just more concentrated a little bit far away from the wall of the blood vessel. But here in the center, we have the still preserved capillary with blood vessel wall, because of the fact that it's not ruptured. It's only it's only with increased permeability, and the erythrocytes move through the gaps between the endothelial cells, and then they go in the interstitium surrounding the blood vessel lumen. So this is the perdiapedesis mechanism. The blood vessel wall is still intact, but only with increased permeability. Did I answer to your question? You good? Okay. Any other questions?
And this white area at the left?
White area? Did you say white area? This thing or what?
Yeah.
Here there is brain edema. This is not a hemorrhage. We have a perivascular space here that is enlarged. And again, this clear space in between the fibrillar matrix of the brain is brain edema.
Okay. And did you say that artery was enlarged?
No, it's not. Not the artery is enlarged, but the space, the clear space around the blood vessel is enlarged because of the accumulation of fluid. Okay, based on the time, the next slide will be the last one for today. It's number 13, gout. On this slide, we have two subsequent slices from the same specimen, so it really doesn't matter which one of them you zoom in to discuss. The first thing that is quite obvious here, I think, is the areas of granulomas. These round two oval structures, these are the granulomas formed in gout. Of course, before that, we should zoom in the other tissues, but here we can't detect the specific parenchyma of an organ. The thing that is visible is connective tissue with fat tissue and blood vessels. So all of these types of tissues and the blood vessels are characteristic for the soft tissues elsewhere in the human body. But when you recognize the process as gout, just theoretically you can guess that perhaps this specimen is taken from soft tissues surrounding joints, because you know that the deposits, the uric acid deposits, are surround the joint. Usually the first joint that is affected is the first metatarsophalangeal joint. So this is the big toe of the foot. And usually the first clinical manifestation of the disease is exactly a really severe pain in the big toe of the foot during the nights. It is quite characteristic for the disease. This is just in case you are asked about these findings. After you mentioned that the specimen is taken from soft tissues because of the presence of connective tissue, adipocytes, and blood vessels, then you concentrate on the appearance of the granulomas. These granulomas are foreign body type because the uric acid deposits are foreign for the human body. They shouldn't be in the soft tissues. That's why the organism recognizes them as something abnormal, something foreign, and sends inflammatory cells to limit these deposits. And the inflammatory cells that are visible surrounding the center of uric acid deposits are lymphocytes. You know that the lymphocytes look just like dots because we can see only their nuclei without cytoplasm. And the other cells that are formed are multinucleated giant cells. They are foreign body type, but not Langhans type, as it's characteristic for tuberculosis and sarcoidosis as well. Here again we have giant cells. So the giant cells are the ones with abundant eosinophilic cytoplasm and multiple nuclei in the center. Or actually the nuclei could be elsewhere in the cytoplasm. This is how we recognize that these are foreign body type giant cells, due to the fact that there is no typical organization of the nuclei within the cytoplasm. They could be elsewhere. So at medium magnification, usually all of the larger cells with more eosinophilic cytoplasm, they are multinucleated giant cells. You can choose an area where they are well visible. Here again, all of these cells are multinucleated giant cells. You know that the disease is a metabolic disease, and usually the treatment is with medication and diet. Patients should decrease eating meat and actually foods that contain purines. Questions? Okay, if there are no questions, this is when we'll finish this class. And you know that at 1 o'clock there will be another one for groups 6 and 9. Of course, if the other groups want to join the class online, it's fine. At 1 o'clock, we will discuss different examination slides from these ones that we already discussed.
I have a question to the exam. How many MCQ questions are there going to be?
There is a question about the MCQ for the exam. There will be 30 questions. You have 30 minutes to finish all of them, and only one is the correct answer. And you can't go back to the previous questions. You should choose an answer and then to continue to the next question.
And then we have the oral, with the microslides and the module.
Yeah, if you pass the MCQ, you need at least 18 points to pass. If you have them, you continue with the practical exam, which consists of one macro specimen from the jars and two micro slides from the ones that we discussed. If you pass this part of the exam again, the last third part is theoretical. You pick up a card with two previously grouped questions. One of the topics is from the first half of the syllabus, and the other one is from the second half of the syllabus. You have the syllabus on Blackboard, right? Yeah, you should have it.
And if we don't pass MCQ, we can't do the rest.
No, if you can't pass the MCQ, this is the end of the exam. You can't continue with the practical part. And if you pass the MCQ,
And I don't pass the macro,
and you don't pass the practical part, so only the MCQ is saved for the exam. Doesn't matter if you fail then at the micro or theoretical part, every next time you start from practical exam. So only the MCQ is saved. Even if you pass the practical part and then you fail on the theoretical topics, the practical part is not saved. Next time on the retake session, you start from the practical part again. But during the colloquium, you already saw some of the questions because for the final MCQ, all of the topics that were included in the colloquium will be the same ones. The only added questions will be from tumors and immunity. These were the topics that were not included. Yeah, this was everything that we discussed after the colloquium. The other questions are the same like for the colloquium. So if the colloquium was easy for you, if you have the notes from my classes, I think you won't have problems with the MCQ because I mentioned almost everything that is included.
I think we're in the
Okay. If there are no
show us where we can find the syllabus.
the syllabus. I think here program schedules, workout syllabus. Conspect GP. Yeah, here this is introduction book. How many questions? 68. For students who are at home, I'll share another screen with you because here I was asked to show where you can find the syllabus in case you don't know it. I'll start from the very beginning. So the syllabus, you can find it in the folder Program Schedules Workout Syllabus. And then in this area, Conspect GP. It is PDF file. And when you open it, you see this document. There are 68 questions. And as I mentioned, for the theoretical part, you pick up a card with previously grouped two topics. One of them is from the first half of the syllabus, and the other one is from the second half of the syllabus. And can you repeat?
You just write everything you know about.
Yeah, you say everything you know. And even if you know one of the topics for a 6, and you were for a 6 for everything so far, And if you say that you don't know anything about one of the topics, you fail. You should say something about any topic and slides and everything you have during the exam.
Okay, so it's oral, it's not even writing.
I'm not sure if you have time for writing, for the practical, for the theoretical part. Maybe you won't have time. Maybe you pick up a topic and you need directly to discuss it with the examiner, but it depends how many examiners there are during your day, and if there is time for you to think about the theoretical topics while the examiner is examining the practical part, another student at the practical part. So it depends. So sometimes they give you time to think about the topics. In some other cases, they want you to say directly what you know.